This conference will now be recorded.
Hello. بسم الله الرحمن الرحيم. Hello. Hello. Hello.
Yes, we can listen.
Okay. Is my voice clear now?
Yes, clear.
Okay, good. Shall we start, inshallah?
Yes.
Okay. Good evening, all my colleagues. Today, inshallah, we will start our first module, early pregnancy care. Today, we'll discuss 4 case scenario for the early pregnancy care. We have 2 instruction discussion task and 2 simulated patient task. We will talk about each one in detail, inshallah. So let's start immediately. Who want to share by the first case scenario?
Yes, Dr. Ali?
Okay, Dr. Shaima. Dr. Shaima.
Yes, Dr. Ali.
Okay. We'll start by first case scenario. As you know, each case we have 12 minutes. So you will have 2 minutes to read the instruction in front of the cubic. You should now have a small paper and pen to write the important point in the instruction and what are the important points you wanted to talk. This will be in the 2 minutes. Try to familiarize yourself by the situation of the exam and practice as you are in the exam. You will have 2 minutes to read the instruction. After that, you will have 10 minutes for the scenario. Okay?
Yes, okay.
Okay. So let me start the time. Okay, this is the first case. We have instruction discussion task. So you have 2 minutes to read the instruction. And after that, I will ask you several of questions regarding to the scenario. Are you ready?
Yes, Doctor, I am reading the task.
Okay, yeah, start. Okay, 2 minutes finished.
Yes. Yes. Okay.
Okay, so now imagine yourself that you are entering in the cubicle and you introduce yourself to the examiner by hello. I am hello. I am Dr. Shaima. I am ready for instruction for the discussion.
Okay. Hello. I am Dr. Shaima, one of the candidates, and I'm ready for discussion.
Okay. Okay, Dr. Shaima, you read the instruction outside the cubicle. And what is the important information you wanted to know from this patient from her history?
From her history, I will at first put in my mind the differential diagnosis in this patient. This patient complained of bleeding in early pregnancy and vomiting. And I will try to ask the question related to this differential diagnosis. The differential diagnosis may be she has abortion, she has early miscarriage, she has recent abortion, she may have ectopic, she may have hyperemesis of pregnancy, she may have a particular mode or twin pregnancy, maybe have other causes of this vomiting. I will start by analysis of the current complaint, since how long she has this bleeding, and this bleeding associated with passage of blood clot or passage of vesicles, and the analysis of the vomiting, since how long she has been vomiting, how many times per day, if she is intolerating to any food or drink, if associated with any pain, abdominal epigastric pain, to exclude the peptic ulcer, loin pain, exclude the pyelonephritis, associated with the dysuria or water work problems, to exclude UTI. I will ask her also if this vomiting starts with recent intake of any medicine. I'll ask her if she had any ultrasound done or no. I'll ask her if she has any medical problems such as diabetes or non-kit to be Helicobacter pylori. I'll ask her how this vomiting affecting her quality of life, because it starts in 5 days.
Yes.
I'll ask her also with whom do you live now, if someone come with her today during this consultation, who is taking care of her at home.
Okay. Any other point you wanted to ask?
No.
Okay. What is the investigation you wanted to know? You wanted to do for this patient?
I see the investigation done already. I want to add the ultrasound. The investigation done. There was the hemoglobin was 11. There was low sodium and low potassium, and the patient was Rh negative. I want to add the urine analysis to check if there is ketones or no. I think I missed. I want to take midstream urine. I want to take the beta HG level. The ultrasound also exclude the vesicular mole or twin pregnancy.
Okay. Any other thing you wanted to add? Okay. This is the history. Okay. This is the history of the patient. Read the history, please.
Okay.
Okay, she is primigravida, spontaneous pregnancy, no previous admission, no previous scan, constantly vomiting for the past 5 days, can't tolerate oral intake, insignificant medical history. And this is the examination of the patient.
Yes.
Okay.
Okay.
And this is the result of her investigation. So, what do you think the diagnosis of this patient?
The diagnosis is complete molar pregnancy with hyperemesis gravidarum.
Okay. Okay. So, how you will treat this patient?
At first, I will discuss with the patient her case, that she has abnormal pregnancy, and this pregnancy needs to be terminated because it will not result in a healthy baby. And I will correct her dehydration and electrolyte imbalance. I will give her, starting by intravenous fluid, the normal saline with potassium chloride, guided by the potassium level. I will start anti-emetic for her, starting by the first line, like the cyclizine 50 milligram IV. Also, I will inform the patient about the need for the operation, suction evacuation. And I take consent for this. I inform her about the possible complications that can occur, like the vein infection, bleeding, injury to the uterus or to the cervix, and that she should have adequate regular follow-up, and we should have a registration for one of the trophoblastic centers with her permission to make adequate follow-up for her, because this condition, there is some cases will need will have resistant trophoblastic cells, and we need chemotherapy later on. Also, as regards the patient is Rh negative, we will going to give her the anti-D, because maybe the time will be delayed until the result of the histopathology will become. Also, I will instruct her that even after she completes her follow-up, for any upcoming pregnancy, she will have she will have to consult the trophoblastic center, and she will instruct her to have a pregnancy test from 6 to 8 weeks after the pregnancy.
Okay. Anything else you want to add?
No.
Okay. Thank you, Dr. Shaima.
Thank you, Dr. Ali.
Okay, you did well, Dr. Shaima. You are excellent, really, in doing this task. You mentioned all the information requested from you in this scenario, except only a small point we will talk about.
Okay,
So
thank you, Dr. Ali.
Okay. So if we wanted to discuss this patient to appear from the start that it is hyperemesis gravidarum. So regarding to the history of this patient, as you mentioned, when you tell or when you ask it in the exam, in the suction discussion task, what is the important point in the patient history you wanted to know? What is the what is the other investigation you wanted to ask? what is the treatment. First, you should introduce yourself to the patient as you are coming to simulated patient task. So when you talk to the examiner, even in the structure discussion task, as you said, I will put differential in my mind. This may be a UTI, this may be hyperemesis gravidarum, gastroenteritis, maybe a appendicitis, any other causes of nausea, vomiting. As you know, hyperemesis gravidarum is a disease of exclusion. So I have to exclude any other causes of nausea and vomiting in pregnancy. And I will introduce myself to the patient and my role and confirm the identity. This is because this patient safety, so you have to explore also this for the examiner. So even in the structure discussion task, when you are asked, when you give the scenario and the first question, mostly it will be what is the important point in the patient history you wanted to know. So I will put differential in my mind and I will introduce myself to the patient and my role and confirm the identity. So the patient wanted to know for whom she will talk and from who she will meet. Then you will do analysis of the complaint as you did. You did excellent analysis of the complaint. We have here two complaints, the vaginal bleeding and the vomiting. You do analysis of the complaint. Could you tell me more about the bleeding? I will ask about the bleeding, whether she has any associated symptom with the bleeding, like pain in her tummy or fainting attack. And this to exclude the causes of the bleeding in early pregnancy, like ectopic pregnancy, like miscarriage. Then I will ask about the vomiting. As you said, you will ask about the duration of the vomiting, the frequency. You forget to mention the weight loss, and you forget to mention whether she tolerate food or drink, the effect of this vomiting in her quality of life, and this to assess the severity of the vomiting. Whether she has any other pregnancy and she has vomiting in previous pregnancy, because as you know, the hyperemesis may be recur in the subsequent pregnancy. We'll ask about any other symptom associated with this vomiting, like headache, like blurring in vision, to exclude CNS causes, any pain in her tummy, any loin pain, to exclude UTI, any problem with her urination, to exclude also UTI. So you will do as you are in a simulated patient task. You will do analysis of the complaint. So you will go to the obstetric history. I want to ask her about this pregnancy. I will ask about whether she has any scan in this pregnancy, any previous admission in this pregnancy, whether she was pregnant before. This is will be the past pregnancy to know whether she has hyperemesis in her previous pregnancy or not. I will ask her about the last menstrual period to know how many weeks she are pregnant. Cervical smear, as I said, I prefer to put it in every scenario in any patient more than 25 years, and this will be considered as a patient safety. So I may also ask her about her cervical smear as a safety point. Medical history, whether she has any diabetes, any thyroid that may be associated with vomiting, any surgery in her tummy before to exclude ectopic, because the patient may have vomiting and this vomiting may be associated with the ectopic. Any drug to exclude drug-induced vomiting, any smoking, whether she smoke or no, also to exclude ectopic. Support at home, and this to exclude domestic violence. The patient came with bleeding, so she may be exposed to domestic violence. So in the structure discussion task, you will go systematic as you take a history from a patient in front of you, not to forget any point. If you go with this, you will not forget anything. Analysis of complaint, obstetric history, gynecological history, and medical surgical history, drug, smoking, and social habits, and the social history and support at home. You will ask about the relevant question. Okay, regarding to the other point you wanted to know, the question, the other point you wanted to know from the patient, don't forget examination, because examination will be also a point from information gathering. You will collect information from the examination of the patient. Please don't forget this. So as I said, go as you are seeing a patient. You will take a history, you will do examination, and you will request investigation, not to forget any point. So I need to examine this patient in the presence of chaperone after taking her consent. You should say that to the examiner. You should say that I will examine the patient in the presence of chaperone after taking her consent. And this because will be considered as patient safety and communication with patient. What we will do, general abdominal examination, pulse, blood pressure, and temperature to be sure that she is hemodynamically stable. Abdominal examination for what? For fundal level, because she may be molar pregnancy or twin pregnancy. Any abdominal tenderness, any lion tenderness to exclude gastroenteritis and urinary tract infection. So you should mention also examination. Regarding to the investigation, yes, as you mentioned, there are some investigation, and the investigation show that this patient has hypokalemia and hyponatremia, and this will go with hyperemesis gravidarum and slightly elevated liver enzyme, as we said. Okay, and this also can happen in the hyperemesis gravidarum. So I wanted to ask for also urine analysis, as you said, for ketonuria, to see whether any ketone or no, to see whether the patient is dehydrated, because it will affect my treatment, whether this patient need admission or no. And ultrasound, for what? You did good in mention, and you justify yourself why you do urine analysis, why you request urine analysis, ultrasound. The ultrasound to see whether this patient has molar pregnancy, whether she has multiple pregnancy, also to see how is her gestational age and the viability of the pregnancy. So you mention all this investigation good. This is the history, as we said: priming, spontaneous pregnancy, no previous admission, no previous scan, constantly vomiting for the past 5 days, can't tolerate oral intake, and insignificant medical history. Okay, by examination, it is not pale, dehydrated, hemodynamically stable, fundal level is 16 week, more than the build of amenorrhea. Weight loss more than 5%, it's 6%. So it will go with the hyperemesis gravidarum. The definition of hyperemesis gravidarum. Okay, what is the definition of hyperemesis gravidarum? Come here. Hyperemesis gravidarum is diagnosed when we have protracted nausea, vomiting with triad of more than 5% pre-pregnancy weight loss, dehydration, and this will be in the ketonuria, and the electrolyte imbalance. So it is hyperemesis gravidarum. The ultrasound, the investigation, there is a ketonuria +3, and the ultrasound show that she has molar pregnancy. So what will be her treatment? You mention all the point in her treatment, but you forget some point. You should mention it also, like this patient from the start need admission. Okay, because some cases of nausea, vomiting of pregnancy may not need admission, but there are some criteria. When we find this criteria, this patient need admission. What are the criteria from the guideline? These are the criteria. The inpatient management should be considered if there is at least one of the following: continued nausea and vomiting and inability to take oral antiemetic, continued nausea and vomiting associated with ketonuria and weight loss, confirmed or suspected comorbidity. So from the history of this patient and from the investigation, this hyperemesis gravidarum need admission. So you have to mention, I need to admit this patient. This will be considered patient safety. If you didn't mention this, you will lose a mark in patient safety. Second point, you forget multidisciplinary team. In a patient admitted with hyperemesis gravidarum, as from the guideline, she need multidisciplinary team. They like this expression very much. They like the multidisciplinary team. So if the case request multidisciplinary team, you have to mention multidisciplinary team. And who will be in the multidisciplinary team of this patient? You should mention, not only mention multidisciplinary team and that's alone or that's enough. No, you should mention who will be in this multidisciplinary team. This patient need the obstetrician, the nutritionist, the dietitian, the pharmacist, and don't forget the specialized nurse. They also like the specialized nurse. Okay, so this patient need admission, multidisciplinary team, and as we said, don't forget the multidisciplinary team. Even this patient may need psychiatrist when you revise the guideline. Okay, after the admission and the multidisciplinary team, the best treatment for the patient are the rehydration with electrolyte correction. Rehydration fluid and electrolyte. And what is the best regimen for this patient? As we from the guideline, it will be the normal saline with addition of the potassium chloride in each bag, with daily monitoring by serum electrolyte each day. Okay, what will be her second treatment? The antiemetic. Okay, from the guideline, he will ask you, the examiner will ask you, what are the classification or the classes of the antiemetic? We have 3 classes of the antiemetic: first line, second line, and third line. And these are categorized according to the safety and efficacy. Okay, you can revise this from the guideline. So the antiemetic, antacid if the patient has gastritis, thiamine, we also give the patient thiamine, especially the one who take dextrose, we will give her thiamine. You forget a very important point, Dr. Shaima, forget low molecular weight and stocking. It will be also safety point for this patient. So safety point and applied clinical knowledge. So please, any patient admitted with hyperemesis gravidarum, don't forget thromboprophylaxis by low molecular weight and stocking. And this will be continued till hair discharge. Am I clear? My voice is clear?
Yes.
Okay. So don't forget, please, low molecular weight and stocking. As we mentioned, daily serum electrolyte, monitor the input and the output. And you did well in saying and mention baseline beta HCG. Baseline beta HCG, I will request here baseline beta HCG because this patient molar pregnancy and I have to follow her. Okay, regarding to the molar pregnancy, it will be breaking bad news. You didn't mention, Dr. Shaima, this also, this will be communication with the patient, breaking bad news. This, as you said, as I said, imagine yourself seeing a patient. So if you will treat a patient with a molar pregnancy and you wanted to tell her, so you have to tell her in breaking bad news manner or breaking bad news way. So you have to tell this for the examiner to show the examiner your skills in communication with the patient. Very important to show the examiner. Imagine yourself, as I said, you are in front of the patient. So doctor, this is a case of complete molar pregnancy. So I will inform this patient in breaking bad news way. So I will tell her that if she wants someone to be with her, then I will give her warning sign that we have not good news today. Then I will explain for her the molar pregnancy. Okay, so I will inform the patient in breaking bad news, and this patient needs suction evacuation. And you did well in justifying the anti-Ds. Yes, complete molar pregnancy don't need anti-D because she doesn't have RBCs. But you justify, you may give her anti-D because the result of the histopathology may be delayed, so you can give her the anti-D. Okay, you mentioned registration in the trophoblastic screening center, and this patient also needs follow-up. And how will be her follow-up? Her follow-up will be by repeating the beta HCG weekly. till the beta HCG become normal or negative. If it happen within 8 weeks, 56 days, so it will continue her follow-up for 6 months from the date of the surgery. If not, we will continue for her the follow-up till 6 months from the date of the normalization of her beta HCG. This patient should have a contraception. You forget this point. Also, patient safety. This patient should have contraception till her follow-up finished. You did well in mentioning the ultrasound in early pregnancy in the next, and she need her to do beta HCG after her pregnancy by 6 and 8 weeks to exclude recurrence of the GTN. I will give the patient information leaflet to read about her molar pregnancy. Okay, any question?
Hello, Dr. Ali. Good evening.
Good evening.
Doctor, one question I want to ask. In case if we need to give dextrose to the patient, IV dextrose,
Yeah.
and there is a risk of thiamine deficiency and this vernix encephalopathy.
Yes.
So if in case the question is coming like this, how to answer?
If we have to give the patient dextrose, so her sodium level should be normal as the guideline mentioned, and I will give her parenteral thiamine 100 milligram daily.
100 milligram daily. Any recommended duration, doctor? Like over 4 hours, 6 hours, anything like that?
No, it will be given as I know, it will be given IM and this thiamine. Every day you will give her this 100 milligram of thiamine IM intramuscular during the days of the admission of the patient.
Okay, okay, doctor. Thank you.
Okay.
Doctor, the fluid of choice in case of hyperemesis will be sodium chloride with potassium chloride in it. Is it?
Yes, this is the best regimen for the patient. It will be normal saline with addition of the potassium chloride.
Doctor, can you just confirm how do we introduce ourselves in structured discussion? Like we are going to face the examiner, not the role player. So how do we introduce ourselves? Can you please tell the exact line how to introduce ourselves?
Yes, hello, I am Ali, one of the candidates, and I am ready for discussion.
Dr. Ali, is this looks okay? I'm ready for the discussion. I mean, is it okay? Yeah.
Yes,
To say
you can say I am ready for discussion, or you can say hello and sit. Some candidates do like this, and there is no problem at all. Some of the UK courses said that you can say hello and sit. Don't say anything more than this. So you
okay.
can say hello and sit, or you can say hello. I am Ali. I am reading. I read the instruction and I am ready for discussion.
Okay, doctor. Thank you.
Okay, welcome. So can go to the second case. Who wanted to share? Anyone wanted to share?
Hello, doctor. I can do the keys.
Okay, Doctor
Jyoti.
Jyoti.
Yes.
Okay, welcome, Dr. Jyoti. Okay, you can do. You have 2 minutes from now to read the instruction, and after that we will go for the case directly. Okay,
Yeah. Okay, doctor.
start.
Okay. Hello, can I start, doctor?
Yes, you still have time for the 2 minutes if you wanted to gain benefit. If you want to start, okay. We can
Yeah,
start.
I
I
can
will
start.
adjust my time. I will adjust my time
Yeah.
first, then we will start. Okay.
Okay.
So now you have 10 minutes. Start, please.
Yeah, okay. Hello, Mrs. Sarah Smith.
Yeah.
Good morning. My name is Dr. Jyoti. I'm one of the doctor today in the clinic.
Hello, Dr. Jyoti.
May I know your age, please?
I am 32 years.
Can I call you as Sarah?
Okay, doctor, you can call me Sarah.
Okay, thank you so much. So, Sarah,
Welcome.
I can see that you have come today to repeat your blood investigations and with ultrasound reports to discuss the report. Am I right?
Yeah.
Sarah, actually, I'm meeting you today first time. So I would like to ask some questions to you, and after that, I will discuss the report with you, and we will make a shared decision and management plan together. How does that sounds with you?
Okay, doctor, no problem.
Thank you, Sarah.
Welcome.
So, Sarah, I can see that from your file that you have come before to do the test, and you were having some pain in your tummy, and you were having some bleeding.
Yes.
How are you now, Sarah? How is your pain and how is your bleeding?
Yes, doctor. I am now fine, except some pain on and off in on my right side of my tummy, and I am really worried about my test. I wanted to you assure me about my result, please. If my pregnancy is healthy?
I will shortly come back to the report, Sarah. And you want any painkillers right now?
No, I can manage.
Okay, okay. Thank you so much, Sarah.
Okay,
So,
welcome.
this is your second pregnancy?
Yeah.
Previously, you had one delivery. It was a smooth delivery. There was no any problems in that pregnancy and delivery.
No, it was a vaginal delivery in the hospital, and there was no any complication.
Okay. Uh, are you following with your GP for any medical illness or medical issues?
No, no,
Okay. You have any surgeries down in your tummy or down below?
no.
What about your smears, Sarah? They are up to date and normal?
Yes, it's up to date and normal.
Okay. You came today with your partner?
No, my partner in the work.
Okay. You want to call your partner with you, or you want me to call any staff with you?
Why? Why, doctor, you wanted to call my partner?
Because Sarah, you have some run blood test for you, and you have the scan done for you, and I'm afraid that the scan results are not having good reports, good results. So I just want to discuss with you, with someone will have with you, that will be good for you.
Oh my God. What happened, doctor? You can't tell me directly. I'm afraid right now.
Do not to be worried, Sarah. I just want to discuss with. Okay, I'll come to the reports for you. You have done the hormone, we call hormone test. That is a protein which is increased in the in our blood during the pregnancy. Okay, and on your first report, it was the level was 2900, and the women who are having healthy pregnancy inside their womb, usually that hormone levels will be double in coming 48 hours.
Hmm.
Are you with me, Sarah?
Yes, I'm following you, doctor. What happened?
Yeah. So after the 48 hours, the result has shown that the level is 3900. Okay.
And what does mean,
So
doctor?
it was supposed to be nearby. Hello.
Yes, hello, I am following you, doctor.
Yeah, but this result has shown that it has not increased in the level which we are expecting at this gestational age.
Hmm.
And the ultrasound you have done, in ultrasound in your womb.
Hello? Hello? Dr. Jyoti? Hello? Hello?
I think she got disconnected.
Yes, I think that. So, anyone else wanted to complete?
I would like to. May I?
Okay, if you wanted to start
Yeah.
from the end, or you will start
No, I'll start from the beginning.
from the beginning. Okay. So I will adjust another 10 minutes.
Okay.
You read the instruction?
Yeah, I've read.
Okay, yeah, start.
Okay. Hello, I'm Dr. Tulika, one of the doctors in the clinic today. May I know your name and age, please?
Yes, I am Sarah Smith and I am 32 years.
Okay. What should I call you?
Call me Sarah.
Okay, Sarah, as I can see from your GP's letter, this is your second pregnancy, right?
Yes.
And
Hello, Dr.
you,
Ali. Sorry, there was some internet connection problem.
Oh
Hello.
my God. Okay, Dr. Jyoti, you came back.
No problem.
Okay,
No
Dr.
problem.
Tolika.
she
Okay.
may continue.
Okay.
It's okay.
No, actually,
Okay,
it's
Dr.
there was
Tolika,
some internet
you
problem.
can be for the next one, Dr. Tolika, okay?
Okay, no problem.
Okay, thank you very much. Thank you for your
Thank
understanding.
you. Yeah.
Thank you.
Sorry, doctor. There was some internet problem. I don't know what happened.
No problem, Dr. Jyoti, no
So,
problem at all. Okay, okay. So we arrived till you are explaining for me the ultrasound scan. Okay, you can complete.
Yeah. So as per the ultrasound report, it's look like you are having most likely ectopic pregnancy. We call it as the pregnancy which is that growing outside the womb. So let me draw you Sarah to explain you more clear that like this is
Yeah.
the womb and these are the tubes and this is called your ovaries. So the egg
Yes.
will be fertilized. The egg will be fertilized in the tube, part of the tube, which is this is the part. And then in the normal pregnancy or normal conceptions, this fertilized egg will move from the fallopian tube into the womb, and then it will be healthy pregnancy grows and develops till complete 9 months, and then you will have the baby. But if this does not happen, like the pregnancy will be the fertilized egg is still in the tube and it will start to grow inside the tube only, that we call as a ectopic pregnancy. It's not necessary that it
Oh my
can be
God.
in the tube, it can in another place also. Am I clear, Sarah?
Yes, doctor, you are clear. But how this happened? Why this happened, doctora?
Actually, it's not clear that exactly why it happens, because mostly maybe it is having some there are some
No, I
infections
know.
in the
I
past.
spoke very much, doctor. I spoke very much, and my midwife told me before that I have to stop smoking because this may affect my baby. So I have killed my baby.
Sarah, don't blame yourself. Actually, this can be one of the contributory factor to this development of this kind of pregnancy, but this is not the exact reason we can say. There are other things also, like maybe sometimes you are having maybe some kind of infection in the tube or some vaginal infections that can also cause. Sometimes if you're taking some pills to control your, like a contraception, or woman will have previously have suffered with any surgeries for the tubes, this kind of woman can get
Okay,
this
doctor.
type
So,
of
so doctor, so you
pregnancies.
can do anything to put my baby inside my womb?
Actually, Sarah, I'm afraid to say you that this pregnancies has to be treated, and there is nothing like we can take these fertilized eggs and put inside the womb. Because if we will not treat this, it can grow bigger and it can burst your tube, and you can have the internal bleeding that can be
So how
life
will be
threatening
my
for
treatment,
you.
doctor?
Hello.
So how will be my treatment, doctor?
Actually, your levels has the hormone, which is protein levels, has still in the range that if you are agree for the regular follow up, I can discuss with you the medical management and the surgical management.
Okay.
First of all, I would like to inform about medical management to you. Medical management is possible if the patients are ready to have a regular follow up anytime. If more pain or any sudden shoulder tip pain or any tummy pain or bleeding, if you have easy access to reach to the hospital, because with medical management as well, there are little number of women, they need also surgical management. Am I correct to you?
Yes, you are clear, doctor. So what will be? Sorry, time finished.
Sorry, doctor. Yeah, because there was some problem also, and I would like to discuss with her more in detail. Sorry.
Yes, you discussed in details. In some point, you have to escape from this point quickly because only you have 10 minutes during the
Yeah, and I would like to
examination.
take, I was about to take only relevant history. I don't want to go in the detail because It happened with me in the last exam. I was taking too much detailed history and I could not reach to management.
Yes, yes. So taking history, as our mentor said, is art. So you have to practice with your partner which point in the history you wanted to ask. As we said, a relative history or brief history, and the other
Yeah,
point to talk about the treatment quickly to mention all the point. So there are some point you forget. You take history very much. Your communication is good with the patient from the start. It appear from the start to introduce yourself and confirm the identity of the patient and checking the
yeah.
purpose of the patient, purpose of the meeting, and putting the agenda was very good. Taking the history as
Thank you.
we said, yes, was good, except some point in patient history, like the social habit as smoking and alcohol, because this patient is cigarette smoking, so this also will be a risk factor for the ectopic pregnancy. Don't
Yeah,
forget, as we said, psychological history in all patients in the antenatal period. Uh, put yourself in a safe side. Don't
yeah.
forget that you don't. It will take from you 20 seconds or 30 seconds to ask about the whole question for the psychological problem. During the last 4 weeks, have you been bothered by feeling low? During the last 4 weeks, have you been bothered by loss of interest in doing things? Then ask open question better. You ask about the previous pregnancy in details, and you ask to close the question. If you said, could you tell me more about your previous pregnancy, it will be better and it will save your time.
Okay. Because it was given in the scenario, so I couldn't ask.
Yes, you can say, I understand that you have one delivery before. Could you tell me more about that? She will say, yes, it was vaginal
Yes.
delivery and there was no complication. Okay, so thank you.
Okay.
Go to the next question. After the history, you forget to examine this patient. You have to examine this patient because this patient is ectopic pregnancy. So you have to examine also to show the examiner that you are safe doctor. I will examine you, take your pulse, blood pressure, temperature, and examine your tummy to see whether any pain in your tummy, any mass. I will examine you from down below to see any mass, any bleeding. This will also show the examiner that you are safe doctor. And don't forget, after taking her consent and in the presence of chaperone. Also, in the history, you forget to ask about any fainting attack at home, because any shoulder pain. This because she has an ectopic pregnancy, may have this other symptom, and this symptom of ectopic pregnancy. Coming to the explaining the result, you did the breaking bad news in a good way, asking about anyone to join her. But when he give you, he will give you, if he give you a result of investigation in your hand, and you have to explain this result to the patient, you should confirm the patient identity again. So, Sarah, can I confirm your name, please? Can I confirm your name again, please? So she will say, yes, Sarah Smith. So you confirm the patient identity before explaining the result, because this result may not be for this patient. So when you explain the result or investigation for any patient, you have to confirm the identity. It is very important point in patient safety. All
But
the
doctor,
courses
we've
in the
already
UK.
confirmed in the introduction. Sorry to interrupt. Once we've already confirmed in the introduction the name and age.
Yes, but if you have now another paper, you have a paper for ultrasound or you have a paper of beta HCG in your hand.
Yeah, yeah,
So you
yeah.
have to confirm again the name of the patient. Is the name in front of you the same name in the paper or in the report or no? So you have to show the examiner that you are safe doctor. I will confirm her name and her identity. So please, can I confirm your name again, please? Say, she will say, yes, I am Sarah Smith. Okay. and you will break bad news as usual. I am sorry, it isn't a good news. This is the first warning, and you can give her. So she will say, "What, doctor? What is the problem? The ultrasound has some concern regarding your baby. From the result of the test and the ultrasound, you are likely have an ectopic pregnancy." So, and after that, give her time to react. You should give that time to the patient to react in the breaking bad news. So in the breaking bad news, we will set the scene as you said. Do you want someone to be with you? No, doctor, you can go directly. You can tell me directly. Okay, this gave her the first warning. This not.
Sorry, doctor,
It is
how much time we should give in this case?
yes, 10 second, 5 second, only 5 to 10 seconds to give the
Okay.
patient time to react. She will say, "Oh my God, I am the one that killed my baby." She will cry. She will let her time to react and to show the examiner how you will communicate with the patient. So give her time, and if she cry, give her tissue. Your facial expression here should be reasonable with the case. And after that, Sarah, I am sorry to be a bearer of such news. Can we continue? Do you want me to leave you alone? She will say, "No, doctor, you can continue." Okay, okay, you will explain as you explain. Very good, very good, very good that you are drawing. It is very important, and it will save your time, and it will hide your mark in communication with the patient. They like drawing very much. And ectopic pregnancy is the best example for drawing. If you don't draw in ectopic, you will not draw in any case scenario. So practice by drawing with your partner. Please, drawing will help you and will raise your mark in the exam. So draw as Juti did. I can draw for you, and you draw the womb and the tube and the ovary as you did. Okay, and explain what is her condition like you, as you said. Coming to your treatment, in general we have three method of treatment. We can go either to wait and see, as the patient information leaflet tell us, wait and see, and I am sorry, it will not be suitable for you because your hormone is high, or medical treatment. I know that if you have time to talk, you will mention all the point in the medical treatment and all the point in the surgical treatment. What will be the medical treatment? Yes, the medical treatment, it will be by a drug called methotrexate. And when you mention any drug, please don't forget the mechanism of action and side effect. And if there is dose, you have to mention this dose. So don't forget the mechanism of action and side effect. It will be by giving you a drug called methotrexate. What is the mechanism of action? It will prevent the ectopic pregnancy to grow and help it to disappear. It has some side effect like sore eyes, sore mouth, and abdominal and chest discomfort. Most of the women will need only one injection of the methotrexate, but about 1 in 7, it is equal to 15%, will need a second injection. You will stay in the hospital over the night, and you will come back on day 4 and day 7 to repeat the test. If your pregnancy hormone drop by 15% from day 4 to day 7, then we will repeat it weekly till it become negative. But very important point to tell her about the warning sign. If you have any severe pain in your tummy, if you have any severe bleeding, you are feeling unwell, you should come immediately to the A&E department. If the pregnancy hormone not drop by 15%, you may need second injection. And as we said, this may happen in 1 in 7, 15%. After taking the methotrexate, you should avoid contraception. You should avoid pregnancy by using reliable method of contraception for 3 months. Regarding to the second point, Sarah, the third option, it will be by surgery, and this to remove the pregnancy. This will be by a laparoscopy, and you have to explain what is this laparoscopy. In the patient information leaflet explain it very well. It is a keyhole surgery during which a telescope containing a camera introduced in your tummy through your tummy bottom under anesthesia, under general anesthesia, and this to remove the ectopic pregnancy. After laparoscopy, you will have a rapid recovery and shorter hospital stay. Or laparotomy, and this will be open surgery under anesthesia, but you will have delayed recovery and long hospital stay. During the surgery, we may remove the pregnancy and the tube, and it's called the salpingectomy, and this will give you the best chance to have future pregnancy in the womb. Or to have a salpingotomy, and this by removing the pregnancy and leaving the tube in place, and this can be done if you have another risk factor for fertility, like the other tube damage. If you have salpingectomy, you will be offered during pregnancy test after 3 weeks. If you have salpingotomy, you will be offered a pregnancy test after 1 week, and you may need further treatment by medical or surgical treatment 1 in 5. You should mention all of this. Unfortunately, you should mention all this point in the exam. In the future pregnancy, very, very important point in the patient safety and the applied knowledge, you will be offered a scan at 6 to 8 weeks to check the location of the pregnancy, because there is risk of the problem to happen again, and this will be slightly increased over the general background. In your case, it will be 7 to 10 in 100, and in general background, it will be 1 in 90. I will give you now patient information leaflet to read and discuss this with your partner. Do you have any other question? She will say no. Okay, thank you. Any question?
No, thank you so much, doctor. But I feel like it was really, time was gone for me.
Yes, only time. Time management is very important in our exam, as you know.
Yeah.
Okay,
Doctor,
so by
your
practice.
template is very nice and very informative and very organized.
Okay, thank you. So by practice every day by your partner, 14 case each day, so you will know how you can manage your time in the exam, inshallah. This will be the third case. Who want to share the third case? Dr. Tolika. Dr. Tolika is here.
Yes, I'm here.
Okay, welcome.
Thank you.
Hello.
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 Okay, can we wait 1 minute or 2 minutes till the prayer finish, please?
Okay.
Okay. Okay. Can we continue?
Yes.
Okay. You read the instruction, or you want to still need 2 minutes?
I need 2 minutes. I didn't read.
Okay, yeah, take 2 minutes. I will start now. Start.
Yeah, I'm ready.
Okay.
Shall I
I
start?
will. Okay, I will start the 10 minute. Adjust the 10 minute now. Okay, start.
Hello, I'm Dr. Tulika, one of the doctors in the clinic today. May I know your name and age, please?
Yes, my name is Carla Adam and I am 28 years.
Hi, what should I call you?
Call me Carla, doctor.
Okay, Kaila, as I can see from your papers, this is your second pregnancy. You are 21 weeks pregnant and your anomaly scan shows that there is some problem with the leg of your baby. Am I right, Carla?
Yes, doctor, you are right.
So we are here to discuss the further management. Do you want somebody to accompany you? Somebody has come with you?
No, doctor, I can manage.
Would you like some of our staff to accompany you, or I should start?
No, doctor, you can go.
Okay, Kerala, I'll be asking few questions about you, then I'll be discussing the management options. Is that fine, or you first want me to discuss the management option?
Uh, as you want to, doctor. Doctor, I wanted to discuss. I wanted to end this pregnancy. So, what you will do for me?
Okay, Kerala. So the pregnancy is 21 weeks. If you don't want to continue the pregnancy, then what you have to go through is first you have to get admitted in the hospital. Somebody should accompany you, and then you will be given few medicines. With those medicines, you will start having labor like pain in your tummy, and then the baby will come out.
Okay. Okay,
After
doctor.
that, if the baby and afterbirth come out completely, then fine. Otherwise, if we suspect that some of the parts of the afterbirth are still stuck inside, then you might be taken to the operation theater. You'll be given some painkillers and a small procedure will be done down below to remove the parts of pregnancy if left inside.
Okay. Okay, doctor.
But
No problem.
before starting any procedure, I need to know few details about you. So shall I ask?
Okay, doctor. No problem.
Okay. Tell me more about this pregnancy till now. How have you been doing till now?
Yes, my pregnancy was okay, no problem at all. And I did some tests in the start of my pregnancy, oral okay. And
Okay.
also I did the Down syndrome screening, and it was normal. I did scan in
Okay.
the since 6 weeks, and it was normal, no problem at all.
Okay.
Only the animal
Okay.
scan show that. Mm,
Okay. I'm so sorry to hear this. Was this a planned pregnancy?
yes, it was planned pregnancy.
You took folic acid before conceiving and continued it for first 3 months?
Yes, I talk already.
Okay. Is somebody in your family or your husband's side suffer from such abnormality as we have detected in this baby?
No, first
Uh,
time.
have okay. Have you undergone any surgery ever on your tummy or down below?
No, no at all.
Do you have allergy to any medicine or food items?
No.
You know your blood group?
Yes, O positive.
Okay. Do you have any inhibition to blood transfusion if required?
And shall I require blood transfusion?
In very rare instances, you may require blood transfusion, but it's important for me to know.
No problem. No problem at all.
Okay. Has anybody, you or any close relative of yours, ever suffered from clots in the legs or lungs?
No.
Have you felt low or felt a loss of interest in activities in last few weeks?
After knowing the result of the exam, maybe I feel depressed sometime.
Yes, yes. I'm so sorry to hear this. I understand. I understand. What do you do for a living?
I am a teacher.
And whom do you stay with at home?
My partner.
Is he supportive to you?
Yes, my partner is very
Okay.
supportive.
Okay. Have you get your smears done regularly? You got it done when you were 25?
Yes, it was regular. It was normal.
Okay. So to summarize, Kerala, this is your second pregnancy. You are 21 weeks old, and the anomaly scan shows that the baby has some problem in the legs, and you would like to go for the termination of this pregnancy. Am I right?
Yes. Yes, you are
I'll be
right, doctor.
giving Okay, I'll be giving you patient information leaflet which you can go home and read. I'll also give you number of support groups so that you can talk to the people who have gone through the similar path as you, so that you have some support. I'll also give you 24 hours hospital number so that in case of emergency you can contact us anytime. You may go home, discuss the options with your partner, and you can come back to us. Then we'll give you one tablet to eat. After, we'll get a few paperworks done. After that, from 24 to 36 hours after that tablet, you need to get admitted in the hospital. Am I clear to you?
Yes, you are clear, doctor.
Do you want to ask anything else from me?
Doctor, is my baby, if I left my baby and not abort it, he can or she can walk normal?
The baby will need some support. The baby will need support from a group of doctors, like the doctors who deal with the young babies, the doctors who specialize in bone problems, as well as the physiotherapists who deal with exercise of the people. And together as a team with you, we can make this baby live a wonderful life.
Hmm, hmm, hmm. And maybe other thing in the scan not appear, may have any other anomaly. So I'm afraid from
Yes.
this.
Yes, in certain there are certain anomalies which might be missed on the anomaly scan, and they might get picked at a later date in the pregnancy or after delivery also.
Hmm. Okay, doctor. Okay.
Okay. Do you want to
Thank
ask
you, doctor.
anything else? Thank you.
No, doctor. Thank you.
Thank you.
Thank you, Dr. Aturika. You managed to finish 2 minutes before the time.
Okay. So
So
I asked less. I spoke less. I should have spoke more.
no, you tell most of the point and you did well in the task. But
Okay.
the missing point is that any patient will come to you ask about termination of pregnancy or abortion because she has a small thing like talibus. So you will
Yeah.
go with the patient and you will go with the patient and you will do abortion for her without any trial to change her mind.
Actually, doctor, this
Hmm.
station is in my exam on first day. This station was
Yes,
there,
I
and
was in the same exam. Yes.
yes, and this patient was telling me I would like to have discuss with you options. tell me my baby can
Yes,
play the football, and I give her the full management that how to manage that Ponsati method and to correction of the talipus and all. So
yeah,
it was, the station was not for termination actually. The station was
yeah,
for discussed and make her convinced to go for the pregnancy, like that.
yes. Yes, yes, you are correct, Dr. Ajuti. This was in the exam, so this was a recall, and the task to discuss with the patient and to show your skills in negotiation with the patient. And almost there will be a lay examiner in this task to see how you will react with the patient and how will you will negotiate with the patient her ideas and her decision. So not any patient will come to ask about the termination because she has talibus, because she has any small or minor anomaly. I will go with her. No, I have to discuss with her the other option. We have other option. We have other treatment. We have other management. So in communication with the patient, you should respect the patient autonomy from the start of the meeting, from the start of the consultation, and this by saying, what is her name? Carla. Carla, I am here today to discuss your concern, and I will try to address all your question. By the end, the decision is yours. This is from the start. You will here respect the autonomy of the patient, and you will show the examiner how you will respect the autonomy. This will be considered as patient safety and good communication with the patient. Uh, um, then you put the agenda as you did. I wanted to ask you some question to know more about you. If she give you time to ask the question, okay. If she didn't give you time and she wanted to know already or directly about her case, about her management option, so you can go directly to her management option. In taking the history, take a brief history because there was no information gathering here. There was no information gathering. So you will take a brief history, only brief history about her previous obstetric history. If she give you any information, the last trimester, beer, cervical smear, smoking, psychological history, is very, very important, and support at home because she may be enforced for this abortion. So this is an important point in the history to ask about other obstetric history, social history, and psychological history because she may be depressed because of this. Then anything you wanted to add, no thank you. So you will come to her concern. First, you wanted to ask why she wanted to have termination. Why? She may has misunderstanding about talibus. She may read a wrong article about talibus. That talibus maybe can't walk at all. Will be major congenital anomaly. So your role in the clinic to correct the patient information if she has any bad idea. So Carla, yes, coming to your concern, could you tell me why you wanted to have termination? She will say, yes, doctor, because I am afraid my baby can't walk. I have a friend and her baby can't walk because he has talibus. And the examiner will see your facial expression when the patient talk. Are you laughing? Are you smiling? Are you neutral face? Or you show expression that you are react with the patient, and your head nodding. Yes, and I totally understand your concern, Carla, and I can see how worried you are. But if you give me some time to explain for you, talibus mean that your baby may, or the baby, you can say the baby, not her baby, because she may be embraced to the patient. So talibus mean that the baby may have inward pointing of his feet, and he or she may have difficulty in walking, but it is correctable condition. The baby may have casting or surgery or special shoes. Here will come communication with your colleague. Communication with a colleague may be considered here in the patient, in this case, as patient safety, even if not mentioned in the start. Here he asks about patient safety, communication with patient, and applied knowledge. Not communication with colleague, but it may be considered as patient safety communication with colleague. I can refer you to a baby surgery doctor can explain this for you. Also, Carla, I can refer you to specialized center, the fetal medicine unit. It's very important to mention this center for this patient, where you will have a detailed scan by experienced doctor to see whether you have any other congenital anomaly in your baby. You may have another test called amniocentesis, where there will be a needle introduced through your tummy under ultrasound, and this to collect a small amount of your baby, a small amount of the water around your baby to see the genetic makeup of your baby. But there is risk of this procedure about 1 in 100 to have a miscarriage. You will be given a consent and the patient information leaflet before this procedure. What do you think, Carla? Share the patient decision. Share, let her talk, let her share decision. She may say, okay, doctor, okay, you can refer me to this center. You can refer me, okay, to the baby surgery doctor to explain this for me. If she insists, okay, as you said, if you insist to have a miscarriage, you don't need to mention clause C or clause D because the patient know more than you about the clauses. You don't mention that it will be under clause C. Okay, if you insist to have a miscarriage, it should be done before 24 weeks. Okay, this should be done before 24 weeks, as you know from clause C, should be done before 24 weeks, and after approval of two doctor, and you will be admitted in the hospital, and you will be given two type of the drug, as you said, or as you mentioned. The first drug will be mifepristone, and second drug will be misoprostol 24-hour apart. You should mention that if you did this after 22 weeks, your baby need to be injected by a drug called feticide, and this not to feel any pain. As a patient information leaflet, abortion care tell us if the abortion will take after 24 weeks, so we will inject the baby with feticide, okay, to stop the heartbeat of the baby before abortion. Carla, I understand it's very difficult time to hear that from me. You don't have to decide right now. Take your time, discuss with your partner. I will give you patient information leaflet to read and discuss with your partner. And I can arrange another appointment with my consultant to have a friendly talk about that. Okay. Do you have any other question? Thank you. This will be the communication of the patient when the patient come asking about something. About the patient may come asking about home delivery, and she has a previous cesarean section. She may have twin pregnancy and want home delivery. She may have a fibroid and want home delivery. They like these cases very much. The negotiation with the patient. They like this case scenario, and to show how you can negotiate with the patient and how you can share the decision with the patient. Okay, so not from the start. Okay, I will talk with you about the abortion. You will take two type of the drug, misoprostol. No, negotiate. Why? Why you wanted to have a termination? What do you know about Talibas? What do you know about Talibas? She may have misunderstanding about Talibas. Okay, yes, I can see how worried you are, and I understand your concern. And as I said before, I am here today to give you all the information that you need, and I will try to answer your question. But at the end, the decision is yours. So here you respect the patient autonomy, and you gain the patient in your side. You took the patient by these words in your side. So she now will open her chest and will open her ears to hear you, what you will say. He respect me, so what he will say. So Talibas is 1, 2, 3. You will examine that. You will explain the Talibas and what will be done for this Talibas. Okay, and what if she insists for miscarriage? What will be the management? Do you have any modification? Do you have any addition for my opinion for the case? Hello.
Hello, Assalamualaikum.
Alaikum salam.
Yes, Dr. Ali, can you just tell me in the exam scenario, like we have to give her all the options, either to continue with the pregnancy or with the termination. It was heard like how the role player was taking you towards this case in actual scenario of the exam.
It was like this in the exam. the patient came for asking for I think it was discussing the patient option or discussing the patient concern. So for my case, I was examined in on Hong Kong Center. When I asked the patient about her concern, she said, "I wanted to end this pregnancy because I was I'm afraid that my baby can't walk. I have a friend and her baby can't walk like this." So I respected the patient autonomy from the start. Okay, I understand your concern and I am here to give you the information that you need, and I will try to address, I to try to answer all your question, and at the end the decision is yours. But if you give me time to explain for you, and I start to explain in a soft way, and give her the patient, I give the patient time to ask question, give her a chance to ask. The patient was, for me, it was easy patient, and there was a lay examiner in my exam in this patient. So it is this case for communication. The examiner will
Yes, it was
see
the
how
role play
you.
asking the questions in between from you when you started to explain her. So what was the question she was asking you basically in between?
What was the question she asked me? She asked, I think I tried to.
If you can recall, yes, please.
Yes, it was recalled.
Actually, in London, I was there, doctor. Then London exam center, that patient was asking me that if I continue my pregnancy, my baby can play with like other children. He can play
Yeah.
football because his legs will be affected. How, doctor, you are telling that my baby will be normal? Like that question she was asking me.
Yes, yes. For my opinion, you can escape from this point by referring her to a specialized doctor. You can refer you to a baby a surgery doctor. He can tell you more about that, and this will not be missing from your knowledge, and it show how you will communicate communication with your colleague. Okay.
Thank you so much.
Okay, if the time allow you in the exam, you can continue the antenatal care of this patient. You can continue the pregnancy of this patient, so your care will be under a group of doctor, including my consultant and the baby surgery doctor, and you will have a frequent ultrasound scan, and you will be delivered in the hospital, and you will talk about the intrapartum care and how will be her postpartum care if the time allow you. But I think the time will not allow, the 10 minutes will not allow to continue the pregnancy. So at least you have to reach to agreed plan about with this patient, whether she wanted to continue or she wanted to terminate. Okay.
Yes.
Who will want to do or to share the
The next one.
case for?
Yes.
Oh, hello.
Hello.
Yeah, Dr. Ali, one question, please. In such case, when given is it an isolated anomaly, there is indication to refer fetal-maternal and amniocentesis?
Yes, because she may have other congenital anomaly not appear in the specialized in the anomaly scan. So if the patient has any other congenital anomaly, major congenital anomalies, so it will be under clause E. If the patient insists for the termination, it will be under clause E, and this clause E can done under any gestational age, even if the patient came after 24 weeks.
Yeah.
So we have to refer the patient to a specialized center like fetal medicine unit for another detailed scan by experienced doctor and for another amniocentesis for the amniocentesis.
Okay, thank you.
Okay, Dr. Aisha.
Yes.
Okay.
I'll just go through the question.
This is a structured discussion task about case with recurrent miscarriage. So you have 2 minutes now.
Yes, okay, I'll take my 2 minutes.
Okay, yeah. Okay, 2 minutes finished. Okay, I will adjust the 10 minutes. Okay, Dr. Aisha. Start. Dr. Aisha, hello?
Hello, can you hear me?
Yes, I hear you. You can start, please.
Yeah, hello, I'm Dr. Aisha and I've gone through my question and I'm ready for my viva.
Okay. Dr. Aisha, you read the instruction and the data of the patient. So this patient has the current miscarriage. What you wanted to know more about this patient from her history?
Mhm. First of all, I would like to, as she is a case of recurrent miscarriage with uterine abnormality, most likely. And her background is she's a 34 years old lady with para 0 plus 3 having 3 recurrent miscarriages. So in terms of my assessment, I would like to first of all I would like to take her history examination and then followed by investigation. So in terms of history, first of all I would like to know whether how is she coping with the situation, because it may be really very distressful for her to cope with this situation, having the third recurrent miscarriage. I would like to know about that. And for that, she may need support. So I would advise her for the counseling as well. Then I would like to know about the detailed miscarriages of the first trimester miscarriage, that how was it done? Was it spontaneous? Any medical treatment was given, or was it surgical treatment? Then for the second miscarriage, whether it was a spontaneous medical or surgical treatment. And for the third one, it was like it is already mentioned that it expelled by itself. Then after the third miscarriage, was there any need for surgical intervention or any medical treatment was given to her after that? I would also like to know, having a detail and about, and also I would like to know if she had any. Okay. And after the third recurrent miscarriage, I would like to know if any further investigation was done for her to find out the cause of that, why she is having recurrent miscarriages, or whether she was started on any treatment. till now. And then I would like to know, ask her about I would like to ask her about her gynae history, especially about her last menstrual period and previous history of any sexually transmitted infection or any vaginal discharge from vagina. I would like to ask. And then I would also like to ask about her partner history, especially in terms of the age of the partner. Having done that I would like to ask her about any history of diabetes, thyroid, problem, especially if they're uncontrolled. Then then I would like to ask her from her any surgery of any abdomen or pelvis, especially for uterus, or any myomectomy or any least procedure done on the neck of the womb, that is the cervix. Then I would like to ask her from any drug history. Is she on any drug or any allergies? And what about her social history in terms of her smoking, alcohol, and use of any recreation drug? And what sort of support she is having at home? These are the things I would like to ask her from in history.
Okay. And what is the investigation you want to do for this patient?
Okay. For the before doing the okay. In terms of investigation for this lady, I would like to first of all I would like to do the baseline investigations, and then the investigation according to the cause. My baseline investigation for this lady would be her full blood count to specifically to see her hemoglobin and the blood group for the need of the NTD. And then um, I would also like to do vaginal swab, HVS, and along with that antiphospholipid antibodies, which can be taken sample can be taken once right now, and the another would be repeated after 12 weeks, making sure that she is not pregnant during that time, telling her that because the result may be result may not be accurate because of this. Then as she is having third time miscarriage, I would also like to take the sample for thrombophilias and vaginal swab to rule out bacterial vaginosis, and the length of the cervix by doing an ultrasound for the cervical length, especially TVS. And um, and I would also like to know whether her any typing for the baby was done. If not, then I would also like to arrange for that. And depending on the result of the karyotyping, then I would like to order the karyotyping for the parental karyotyping. And as I can see that her ultrasound report shows that she is having a fundal depression with a partial septum in the uterus with a subserous fibroid. So for that, I would like to go ahead with the hysteroscopy, laparoscopy, um, after discussing with my consultant. This all will be done after discussing with my consultant.
Okay. Okay. So what will be the treatment for this patient?
First of all, for treatment will depend upon the cause of the recurrent miscarriage. If there is no any cause found, then the counseling, tender love, and caring will be the treatment for her. But if there's any cause found, like antiphospholipid antibodies, then I would like to start her on aspirin and heparin accordingly. And if the cause is diabetes or thyroid problem, then I would refer her to the endocrinologist, which will try to control her diabetes or thyroid accordingly. And they may need to start her on anti-diabetic or anti-thyroid drugs. And if the
Okay.
cause is cervical weakness, then for that cervical cerclage will be maybe an option considered, maybe an option for her. But before that, we need to measure her transcervical length.
How you will do? How you will do? How you will do? Or how you will know that there is a cause in the cervix?
For that, we need to do a transvaginal ultrasound
Hmm?
to measure the length of the cervix, or we can start her even on progesterone tablets.
Okay.
That is less than 20. I'm not sure, but what I remember is less than 24 millimeter, in between 25 to 26 weeks, the length of the cervix. But I'm not sure for this point. Yeah.
Okay. Okay.
And
Any other?
along with this counseling support, because she not only her counseling for not only for her but for her partner as well will be counseling will be needed. And before and along with that, a need for the folic acid. I will start her on 3 months before folic acid 400 micrograms daily, once daily.
Okay.
And will ask her to book come for an early booking.
Okay. Any other information you wanted to know? You wanted to tell me?
No.
Okay. Thank you, Dr. Aisha. You managed
Thank you.
to finish before 1 minute of the task. And really, you mentioned all the point in the task. From the history till the treatment, you didn't forget any point I can comment. So you did well in this case.
Thank
From my opinion, you will pass in this case. If we wanted to go in this case, the model of answer, this patient need to be treated in a dedicated clinic. It will be in the recurrent miscarriage clinic. Then I wanted to take a history from the patient. What will be the history? As you mentioned, detailed history about each miscarriage, about the gestational age, was missed or living in miscarriage by the ultrasound. She need any surgical evacuation. She did any investigation to know the cause of the miscarriage. She took any treatment at all. What was her partner age? Because age may the partner age may affect the outcome of the pregnancy. If she have any living pregnancy babies at all. I don't know, you ask about the blood group or no? You ask about the blood group?
No, I asked it in the investigations,
Okay,
not in the history.
At least you mentioned I will ask for the blood group, so it will be investigation, and you have to justify for why. If she is Rh negative, she received anti-D or no, or she may be sensitized. The best way you did in systematic way. It was very good to go in systematic way, so you didn't forget any point. Gynecological history, you ask about her period, when, and her LMB to exclude that she may be pregnant right now, and whether she used any contraception, started to use contraception or no. Cervical smear history, as I mentioned, safety point should be in every case. Then I will ask her about coming to the medical history, whether she has any diabetes, any thyroid, because this will be involved in the recurrent miscarriage, and whether if she has thyroid or diabetes controlled or no. Surgery, because she has fibroid, so she has any myomectomy before in her uterus. This patient may have a myomectomy before, and this fibroid is recurrent again. Okay, this patient has second trimester miscarriage. So she did any surgery in her cervix like leads or no. Whether she has any drug allergies, this will be considered patient safety. Smoking, alcohol, and as you mentioned, social history, support at home, very important. And her psychological issue is very important. The partner age, family history of thrombophilia, as you mentioned. Very good, very good. And from the start, you mentioned psychological history and counseling the patient. Very good. It shows the examiner how you are communicate with the patient and how you are a safe doctor. Regarding the investigation, you mentioned all the point. Antiphospholipid, 2 tests, 12 weeks apart. It will be for the lupus anticoagulant and the anticarbolipine. Inherited thrombophilia, because she has second trimester miscarriage, so I will do factor 5 Leiden and the prothrombin G mutation, protein S, protein C, and the antithrombin 3. Suppose from the third concept is to do cytogenic analysis, and if there is any abnormality, we'll refer the parent for peripheral karyotyping. Because she has suspected uterine anomaly, so I will do, as you mentioned, histoscope and laparoscope to differentiate, and 3D ultrasound to differentiate between the septate and the bicornuate uterus. If I suspect from the history diabetes or thyroid, I will do investigation for that. This patient need in her future pregnancy cervical surveillance. Cervical surveillance, it will be done between 16 to 24 weeks, and if it less than 25 millimeter, so I will do ultrasound indicated cerclage. So this patient needs serial cervical surveillance in her next pregnancy. As you mentioned, cervical swab, this mentioned in the patient information leaflet. This patient needs also cervical swab to check for any infection. The treatment of this patient will depend on her cause, and it will be in the recurrent miscarriage clinic, as we said. If the patient has antiphospholipid syndrome, so it will be aspirin and low molecular weight heparin. If the patient has inherited thrombophilia, so it will be treated by heparin because she has second trimester miscarriage. If the patient have abnormal karyotyping, I will refer her to the clinical genetist. He may offer her pre-implantation genetic diagnosis or IVF or anything like that. Regarding to the symptom in the treatment of the recurrent miscarriage, there is insufficient evidence about removal of the symptom in the management of recurrent miscarriage. As we mentioned, in the patient who have second trimester miscarriage and suspected cervical weakness from her history, we have to do either history indicated cerclage or serial ultrasound surveillance in her next pregnancy. And if the cervix is less than 25 millimeter, I will do ultrasound indicated cerclage. Unexplained recurrent miscarriage have a future good outcome only by the supportive care about 75%. Good, Dr. Aisha.
Thank you so much.
Thank you. So we have now open question or open discussion. If you have any question.
Hello, Dr. Ali.
Hello.
Yeah, Dr. Ali, I just wanted to know in the third case scenario in which there was isolated anomaly of talipes. So in this, there was the domain were marked and information gathering was not a domain to be tested. So in this case, we don't have to touch any of the history points like a regular history of last period or obstetric history or medical and social history. We don't have to touch any of those points.
Yes, Dr. Rukaya. Really, there is a debate in this point. And when we was studying in the part 3 and discussing with my mentors and my seniors regarding this point, they said if there is no information gathering requested from you, so you will suspect that there will be a reaction and there will be a drama in this scenario, and you have to touch only the brief history or a relevant history. You can ask only about a small question from her history. You may think that it will help you in your discussion or your consultation, like her previous obstetric history, whether she has cesarean section before or no. This can affect her management or no. Whether she has any medical history, other medical history, whether she has any allergies, because you will give her drugs. This will be considered patient safety. So her cervical smear is very important. Her psychological history, because she has isolated talibus and the patient requesting abortion. So you have to touch this point. Also the support, a very important point to exclude domestic violence. This patient may be enforced for this abortion. So if there is no information gathering, you have to take a brief history, not exceed 1 minute. But if there is information gathering, so you have to take detailed history, both for the history from 3 to 4 minutes.
Okay, doctor. Thank you.
Okay, Dr. Kaya, welcome. Another question? Okay, thank you very much. Inshallah, we will arrange another session in next week. I think it will be in the same time, inshallah.
Thank you.
Okay, which module you want to start? I suggest to start with antenatal maternal medicine, if you like.
Yeah, that will be good, doctor.
Can we do oncology, because maternal medicine and all, they are long topics? Or
Okay, we can do oncology. We can take vote on the group if you want. We can do voting. What do you want? Antenatal maternal medicine or oncology? Okay, it's okay for me both. Okay, thank you for your attendance.
Thank you, doctor.
Thank you very much.
thank you, doctor.
Thank you very much. Thank you.
Thank
Please
you.
be discussed.